Hey guys, am I audible, visible? If so, let me know. Hello guys, am I audible and visible? Hi, hello. Hi, Fakti, how are you? Sorry, I was not available for some couple of days, so we'll restart it. Good evening, Omsi. Good evening, Fakti. Okay, so let's start today's session. It's the same thing what we are going to continue. It's about pathoclinics. A little bit of maybe 1 second. Okay, so we'll have a few cases. Today is about decoding CBC, complete blood count with respect to infections. That's all. There are lots and lots of things in complete blood count. First, we'll see what does a complete blood count mean and where all we can apply them. And we'll see 3 or 4 clinical scenarios where you'll be seeing different types of complete blood count. And maybe you guys will help me to know what is the diagnosis, right? So if you're ready, as usual, thank you, Bhakti. So as usual, let's start with a smile. Find out where is it? Sorry. Okay. Fine. So you guys must have heard about CBC, right? Complete blood count, right? So can anyone tell me where all you guys use in complete blood count? In which all scenario you'll be using in complete blood count? So complete blood count is something which is routinely done investigation for quite a few things, right? Let's say even if it's an fever, simple fever, or some person gets admitted with respect to an breathlessness, anemia, any admitted patient will have complete blood count as a part of their investigation profile, right? First of all, we have to understand where and how is the complete blood count done. It's a completely automated instrument which will give you hemoglobin. In the first trimester done na, using the Newbar's chamber, total count, differential count, everything, it'll give you TC, it'll give you DLC, that's your differential leukocyte count, right? There are multiple new parameters which are being given in new part counters, right? There are new counters which also gives me reticulocyte count. There are new counters which also might tell me, in this sample there are blasts there. Maybe also might quantify the blast, right? These are new things. But the routine, it'll give me TCDCSR. It'll also give me absolute counts. Fine. Can anyone tell me what does it mean by absolute count? Because there are few places where this is much useful, right? Good evening, Siddhi. Where do you use an absolute count? What do you mean by an absolute count? Absolute neutrophilic count, absolute lymphocyte count. Where it is useful and what does it mean? See, generally, a total differential count is the percentage of whatever is there in the total leukocytes. Let's say, for example, 10,000 WBC is there, 80% of neutrophils. That's how generally the DLC will be given, right? Absolute count says that, okay, there are 8,000 neutrophils. Okay, this is very, very important, especially in cases where you have cytopenia. I'll give you an example why it's important in case of cytopenia. In other cases, in a normal routine case, absolute count does not make sense much. This is very, very important whenever there's cytopenia, right? When I say cytopenia, I'm looking at the WBC cytopenia, right? Let's say I have a leukopenia. Just for an example, the WBC count is 2000, okay? In this, 80% neutrophil. Normally, when you see only differential count, can I say 80% neutrophil is normal? It's absolutely normal. Okay, 75-80% neutrophil is normal. But here, of 2000 is 80%. So my absolute count drops a lot. Absolute count will be approximately what it is, 1600. 1600 neutrophil is not enough for my body, right? So whenever I have cytopenia, absolute count tells me the parameter to treat. Because in this patient, neutrophil is very, very low. Though it is 80% percentage wise, but absolute count is very, very low. So absolute count is something which I want you guys to look whenever there is a cytopenia, right? And obviously after that, it also gives platelets. Okay, these are basic parameters. You must have read in your first year. Do you know, guys must have heard about MCV, MCH, MCHC, right? So these MCV, MCH, MCHC, all these parameters with respect to hemoglobin also will be given there. There is a new parameter which might be reading in your RBC disorder called red cell distribution with that also will be given. There's something called an MPV, like a mean corpuscular volume. We have a mean platelet volume also. This also will be given, right? So these are for later discussion. When you go to hematology, we'll discuss more in detail about MCV, MCH, and also about MPV, and also about platelet count. My goal here is to look at this part and the DLC in the next few cases, right? So ready, guys? So I'm going to give you a very simple scenario. One line scenario, not going to clinics at all. One line scenario, and I'm going to display the CBC count, and I want you to look at the CBC and tell me what could probably be the diagnosis. 3-4 cases, few learning points, then let's go. That's all. Fine. Okay. So 25-year-old, fever, sore throat. Can anyone tell me what you think might be the clinical diagnosis? Fever and a sore throat. I'll tell you how a CBC count might help me in decision making also. Fever, sore throat, what do you think will be the diagnosis? Common. Simple URI. Most of us must be having now, right? Flu. Flu is one of the commonest diagnoses in fever and sore throat, right? So clinically, there's a respiratory tract infection. I don't know whether it is bacterial, whether it is viral, right? So though there are clinical evidence for me to tell, yes, it's a bacterial, there's a viral, but still, since I'm talking about the Pathoclinics, I'm more relying on the CBC, that's all. A common cold, viral, upper respiratory infection, that's all, right? Now, this is the patient's CBC, part of the CBC. Can anyone first tell me which are the parameters which is normal, abnormal, and then let's go to the diagnosis. I don't want to jump into the diagnosis. Tell me which of the parameters are abnormal. Yes, MBBS. Yes, WMC, you're right. Facty, you're right. Which the parameters are abnormal? Can I say this is abnormal? 17,600? Yes, it is abnormal. It is elevated, right? Okay. I'll put a question mark here. I'll tell very soon why I put the question mark. 82% neutrophil. MBBS is abnormal, right? Obviously, right? This is also a little bit on the higher side. Generally, I will have somewhere around 70, max 75. Beyond that, I'm going to obviously think it's an abnormal. Raised neutrophils there. Lymphocyte, will I tell it reduce or not? I won't call lymphocyte reduce here because it's being over compensated by neutrophils. That's all, right? It's very high. Absolute neutrophil count is very, very high, right? Can anyone tell me what this means? There's a 6 number of band forms. Have you heard this term band forms? This gives me very important information for me to actually understand what's going inside the body. Tests are screenshots of your pathogenesis which happens inside the body, which I cannot see. Bands are precursor neutrophils. You might have heard that normally from a immature cell, we call it a myeloblast, we'll read them soon. It becomes slowly like a metamyelocyte, then it becomes a band form, then finally it becomes a lobated neutrophil. Okay, that's how neutrophils will go. Okay, so band form means this is nothing but an immature neutrophil. So now you're going to exactly tell me what this means. Fine. Normally in your body and my body, assuming we are normal, I will not have band forms in the peripheral smear. All of them will be in the bone marrow. So you tell me, when will band forms be released? Let's have an analogy. I am having a war going on. All my warriors are being used. My country is saying that since my war is very severe and hectic, please give me the adolescents, untrained people also to the war. So what is the bottom line here? My body is requiring more neutrophils or less neutrophils? My body is requiring very high neutrophils because the disease, whatever is causing the symptom, is making the neutrophils die or making the neutrophils fight, right? Perfect one. See, I have more demand. So please remember, not just here, remember throughout the hematology chapter, whenever I have more demand of a particular cell, the precursor will come outside. That's all. Okay, perfect. Now let's slightly touch base into a simple concept of hemolytic anemia. We'll read them in hematology in detail, but still, have you heard? Can anyone tell me what is the precursor cell of mature RBC? Anyone? The precursor cell of mature RBC. Have you heard about a cell called as an reticulocyte? Have you heard this? This is the precursor of a mature RBC. So tell me, in which condition reticulocytes will be elevated? We are digressing, but we'll come back to this case soon. Perfect, Vamsi. Which condition reticulocyte will be elevated? Can I say when there is more destruction of RBCs? Perfect, guys. Great. Yes. Perfect. So can you name the disease? I'm having more precursor because there is more demand for the RBC. When will be there more demand? Like in this disease, neutrophils were destroyed. Like when I have RBC destruction. Amazing. So in case of an hemolytic anemia, I'll have more reticulocyte count. This is body's hemostasis. Whenever something is used up, my body will automatically load it, right? That's how it is, right? So let's come back to this case. I just erasing this so that we don't digress from our topic today, right? Perfect. So, but please do remember forever, when something is in demand, my body automatically produces more to compensate so that it can come back to normal hemostasis, fine? Perfect. Now, I have a patient with elevated WBC count, band forms is 6, elevated neutrophil. So what do you guys think? Is an acute bacterial infection or it could be a viral infection? What do you guys think? Bacterial, viral. Perfect. Now it's not that difficult here, right? I mostly think of an acute bacterial infection, right? So why is this information very important for me is if this patient would have had a viral URI, I won't be subscribing antibiotics. Antibiotics is given for bacterial infection. So when a patient comes with a symptom, please do not treat the symptom. Treating symptom is fine when there's an emergency. Treating the disease is the right one when there is no emergency. URI is not an emergency, right? So clinically evaluate, does this patient require antibiotic or not based on the parameters. When you go to medicine, Dr. Santosh Sir will definitely tell you how to differentiate viral URI from a bacterial URI clinically. Perfect, done. Not able to do a CBC. Have evidence, then give it if required. If there is no requirement, please don't give it, right? So this is how a simple acute bacterial infection will look like, right? Now I just put here question mark, right? I'll tell you why I put a question mark. Can anyone tell me the patient's age? Do you remember the patient's age? Yes, no, maybe. Do you remember the patient's age? Patient's age was 22, right? So now, if it's a neonate, okay, if it's a newborn, 1 year, right? This, I won't call it a very high thing. Okay, I'll not call it a very high thing. 22 approximate, right? I forgot the age. 25, you're right, MBBS, right? So 25 is the approximate age. So if it's a neonate, if it's a child, 17,000 is not very high for me. In a neonate, it can even be around 18, 19,000. So age is also an important parameter. The values change based on age. A hemoglobin of 11 might be okay in an adult, but a hemoglobin of 11 in a child is not acceptable. It's very important to know the age related standards, right? That's very, very important. So please always keep thinking about that. Fine. Okay. Now let's go to second question. Fever for 7 days, chills and rigor. Unfortunately, I don't have any age. So obviously, assuming it's an adult, right? So same routine. Look at the CBC findings. Tell me what is abnormal here. I'll keep quiet for some time. Learning is slow and steady. So once you learn slow and steady, you will definitely remember things. And very tiny things. Like I said in the introduction, I want you to look at the tiny important findings there. MBBS given with malaria, dengue fever. Okay, clinically maybe raised WBC, almost similar. Neutrophils more, 89% very high. Band forms 11%, 21,000. Assuming it's adult is very high, right? Can I just tell it's an same similar patient of an bacterial infection? Is it okay to call it a bacterial infection? Yes, no, maybe. Great, Vamsi. Great, guys. Great, Siddhi. Band forms elevated. Perfect. Done. Absolute neutrophil count also very, very high, right? Can I say it is an acute bacterial infection? Yes. Okay. Now I'll show you the previous hemogram and this hemogram. I want you to tell, is there any new difference you have seen? Careful, observe. Look at this hemogram. Look at all the parameters. Look at this hemogram. Look at all the parameters. Is there any variation? These variations are very subtle. The one who picks up will become an amazing clinician. What's a variation? Anyone? There are like 6, 7 named parameters there, right? What's the variation? Factor lymphocyte, I'm not worried much about lymphocyte because lymphocytes are anyway less because 89% lymphocyte will be less. Nah? It's a compensatory loss. Okay, so I'll go to this case. Here, eosinophil is 1%. Eosinophil 1% is definitely low. But what is staring for me is eosinophil of 0%. Okay, there's an important clue. Please do remember, these are very subtle clues. These subtle clues help you to diagnose things a bit early, which might even save the patient, right, maybe wrong, but it's very, very important, right? So here, there's a very important finding of eosinopenia. Again, 0%, 1% is not the right one. I have to ideally go with absolute eosinophilic count. For calling it eosinopenia, percentage is not important. I have to go with absolute eosinophilic count, right? Okay, so absolute eosinophilic count, if there's eosinopenia, it's one of the early indicator of sepsis. It's kind of telling my body, I'll tell you the logic behind it, and in future I want you to look where all I want you to look. I'll tell you that also. Logic is simple. I have a bacterial infection. I increase my 70% to 80% neutrophil. I can kill this guy. WBCs are, lymphocytes are coming, eosinophils are coming, right? But this infection becomes bigger and bigger and bigger and bigger. My neutrophil is saying that, or the granulocytes is saying that, I'm not able to kill this guy. So whatever the compartment of granulocyte is, please produce only neutrophil. Ignore eosinophil. The moment my bone marrow starts ignoring eosinophil, it's under threat because I have to kill this severe bacterial infection. So it means a very early onset of sepsis. Basophil anyway, we don't mind. Basophil is very, very, very minimal, right? So this is important. Next time when you see a bacterial infection for 7 days, 8 days, high grade, chills, rigor, 103, 104, please look for eosinophil also. If eosinophil is getting compensated, is reducing because of the infection, maybe it might be a early indicator of sepsis. Keep the patient on close follow-up, give broad spectrum antibiotics so that we can save the patient, right? Okay, this is an important thing. This is one of the important take-home messages of today's case. Fine. Okay, next case. Diagnosis. 2-day-old severe fever. There are endless possibilities, right? If I ask you after 6 months, you'll write an essay for a 2-year-old with lots of fever, right? Our goal is this. Okay, anyone? Anyone? What do you guys think? It's a simple case. The moment you go to internship, these are something which you will definitely see on a day-to-day basis. Vamsi, I'll take your question. Let you guys comment on this. I'll take a question. Less WBC, less neutrophils, raised lymphocytes, decreased neutrophils. It's chronic, okay? Raised lymphocytes. Okay, I'll take your question, Vamsi. See, Vamsi, I have a WBC count of 10,000. Considering, let's say, the normal scenario, let's say I have 70% neutrophil, 30% lymphocytes. Just for comparison, I'm ignoring the rest. Okay. Now here, if I have 89% neutrophil, I can have only 11% lymphocytes. This is due to the overproduction of neutrophils. This is not a lymphocyte reduction. This I'll call it a neutrophilic predominance. Because of elevated neutrophils, I have a problem. But on the other hand, when you say that time, no, the WBC count also will elevate. Like say it became 15,000. So neutrophils are produced in normal number. Absolute count is very important for me than the percentages. Fine. Let's come back to this case. Anyone, what do you guys think? Fakti said it's chronic. Siddhi said it's viral. Neutropenia. Okay, I'll go with Siddhi's answer. 2-year-old with severe fever, unlikely to be chronic clinically. It's a bit difficult to tell chronic infection with WBC parameters alone. I need a clinical correlation also, Fakti. Fine. Now tell me, why did you say viral infection, Siddhi? And this and question is open to everyone. Why viral? What are the pointers to viral? There are multiple pointers here to viral. I'll show you one by one. Slight reduction of WBC count is one of the commonest indicator of viral infection, mild leukopenia. This might even happen before lymphocytes elevate. That's important, right? Again, mild neutropenia. Mild leukopenia. Fine. This is very, very important. Even before, like first day of fever, you take a CBC, mild leukopenia will be there, right? That's one. And this also, platelet counts being reduced. That's another. 63% lymphocytes. That's other. It should be actually 3800. It's a mistake. That's why I put as mild neutropenia. Fine. This is also elevated, right? So all these points to viral infection. Okay, perfect. Again, Siddhi, I will not call it low neutrophil. Same explanation like what I gave for Vamsi. Here, I call it lymphocytic predominance. Since one guy becomes too much, the other guy looks small. That's all. Fine. So I have a mild leukopenia. I have a elevated lymphocytic count. I have reduced platelets. Fine. Okay. If I have to tell, if I ask you like what viral infection, what will you say? What viral infection? What will you say? See, this is something which I frequently encounter when there's a young physician, a MBBS pass out, starting to see patients. The first thing they'll say is, dengue fever. Because unfortunately or fortunately, throughout your 4 years of MBBS, what I have been taught is dengue fever will have low platelet count. Dengue fever, there will be petechiae, hemorrhage, rashes, and everything. Right? This is kind of into the head. Every single university exam paper will have this question: dengue fever, low platelet. Viral infection, dengue fever. Right? I am not denying that. Please remember, this picture can be seen for almost every viral prodrome. Prodrome means the initial symptoms. COVID will have the same finding. Respiratory syncytial virus, a virus in the URI, will have the same finding. So you cannot say it's a dengue fever based on platelet count. First thing, please remember this forever. Because when you come back to your internship and become a post-intern, I don't want you to say it's dengue fever from CBC. Clinically, bone pain also, fatigue also is common for everything. The only way to confirm dengue fever is there's an antigen test called an NS1. That only will confirm dengue. Nothing else will confirm dengue. That's first. Okay. Second, there is one more very wrong practice going on. Okay. It's 1.12 lakh, right? What will you do next? Without much knowledge of what happens in real life, because you're young, you're in second year, what do you think will be the next? Will you repeatedly monitor this or you won't monitor it? We generally think like, it's 1.12. Tomorrow do one more. Day after do one more. Day after do one more. This is what we generally do, no? It's reducing or increasing, I have to know. Okay. For any viral, again, not only for dengue fever, for any viral infection, what happens? There's a curve, right? Let's say this is 1.5 lakh platelet. Okay. 1, 2, 3, 4, 5. Okay. So from 1.5 lakh, it'll drop, it'll drop, it'll drop, it'll come up. Slowly, around 5th day, it'll definitely come up. I would say do not. Doggy, I am not able to understand your question properly. Fine. If you're talking about growth spurt, around 13 to 17 years. Fine. See, we need not monitor. Again, I've been telling to almost every physician who sends a platelet count for us, they will keep on sending again and again and again platelet counts. Please do not do repeat platelet counts. The only thing I have to monitor, if it's, let's say, I'm having a classical case of dengue fever, proven by NS1 antigen. That's a confirmatory test, right? Here also, please monitor clinically. Again, when you go to medicine, you'll know much about it. Pediatrics, you'll know much about it. One of the important things is my blood pressure, BP, and the edema if is there or not, and few clinical signs. Monitor clinically. Don't prick the patient daily. It will dip, it will rise. Maybe do one at 4th day. Okay, let's say 1.5 is normal, first day is 1.12, 4th day is 1.1, or let's say 1.0, mild dip. It is fine, it will come back to normal. Don't prick every day. Don't waste the blood, don't waste the money, don't waste the resources. That's how diseases are. By daily monitoring, you will not save the patient. Do maximum 4th day if required. Again, I promise you, if it's a simple dengue patient, 4th, 5th day, the patient will walk back home. You don't need to do anything. If it's a very complicated dengue, there's something called dengue hemorrhagic fever and dengue shock syndrome, which is very complicated, where this will go haywire. Patient will lose, BP will be gone, PC will increase, lots of things will happen. So monitor clinically, Use lab test whenever is required. And this is the routine for every viral infection. Fine, done. Last guy, case 4. Yes, Bruno, around 13 to 17 years, approximately the growth spurt might be there. 3 months of chronic cough, mild fever. Clinically, any diagnosis, any possible diagnosis, whatever comes to your mind? What do you guys think? Anything which comes to your mind? Be right, wrong. Okay. What do you guys think? Great, Fakti. TB will definitely be on diagnosis for me because 3 months cough. The first guy is I'll think of TB. Okay. I'll also write here. Okay, TB might be the most probable diagnosis. Now this is the blood test. What's next? What are abnormal first? We'll follow the same routine. Tell me what is abnormal, then we'll see what it is. Siddhi, ARDS is acute respiratory distress syndrome, right? Cannot be for 3 months. It's a sudden failure. I'll keep it as TB. Fine. Commonest diagnosis. What is wrong in this? WBC count reduced? Absolutely yes. Lymphocytes are 26%, but absolute lymphocyte count is pretty low. Lymphocytes are reduced. That's why I said my absolute values are more important than the normal ones, than the percentage ones, right? I have reduced WBC, I have reduced lymphocytes, monocytes is little bit elevated as well, right? Now can anyone tell me, is there anything else you will suspect apart from TB? I am not denying taking away TB here. Is there anything which is not fitting into TB here? Monocytes, will it be elevated in TB? Yes, no, maybe. Absolutely yes. You will have elevated monocytes in TB, right? Lymphocytes, will it be elevated in TB, reduced in TB? Tuberculosis, you have granuloma, na? To form granuloma, you need more lymphocytes, right? You need more lymphocytes, right? So now, what is not fitting into my clinical TB diagnosis is this guy, right? It's reduced, right? Rajiv, you're hinting on something. Can you concretely say something else? You're in the right path of thinking, Rajesh Sharma. What is next? I think Rajiv is trying to say, could it be an immunity problem disorder, right? Low immunity disorder. That's what I hope you're trying to hint. We'll think in terms of whatever Rajiv said. Is there a possibility for this patient to have reduced immunity? Can we think it that way? Yes, no, maybe. Possible, na? So this patient has reduced WBC count against TB, reduced lymphocyte count against TB. Why it could not be perfect? Patient could not be immunocompromised. Possible. Now, if you think the patient is immunocompromised, the patient has clinically tuberculosis, WBC parameter says patient is immunocompromised. What will be the next test you will do? I think MBBS answered that. 2 question marks. I want 1 question mark. Malignancy might not have that much of immunocompromised state. We'll read more about neoplasia in future, but might not. Always want to look for HIV/AIDS because HIV and TB co-infection is very, very, very common. One of the most common opportunistic infection which comes in HIV/AIDS is tuberculosis, right? So I'll have to think of HIV. I'm not saying this patient is HIV positive. I might or I have to suspect HIV infection because of the immunocompromised state, and the TB also is very common in HIV patient, and please investigate for the HIV. Yes, we'll have to treat TB and HIV together. No, we'll have to see why there is such low immunity in spite of the patient having a TB infection, right? Okay. A CBC can give me multiple things. It can give me a clue for another disease like this, right? It can tell me what's happening inside the body and when I should do the test and when I should discharge the patient and monitor the patient. It can also tell me, okay, this is a very, very early sign of something which might be very serious. So please alert, go and treat. It can also tell me as simple as whether it's a bacterial or a viral for a sore throat. whether I need to give antibiotic or not to give antibiotic, right? So I have very few basic things, where samples where you can use CBC. The knowledge in depth helps you to delineate tiny possibilities, and these tiny things will make sure you become an amazing doctor. I always say that distinction on EPG first rank is never the goal. When I'm sick, I need good doctors. For that, let's train them the best way possible to my knowledge, and let's see. Hope I have much more confidence in you than you have, right? You'll definitely do well. Okay. See you in the next class. Till then, bye bye. If you are an Nishtay student, see you around 6:30. We'll start immunology there. MBBS, these classes, I want it to be less heavy. I want to take for 30 minutes, 25, 30 minutes, so that we learn something out of it rather than it being a burden. Okay. Any questions? Let me know. The PDF will be there in the Telegram group of PW. Take it from there.